Hello, everyone, and welcome to another edition of the Robert Johnson Foundation System for Action Programs Research in Progress webinar series. Thank you for your patience while we address a couple of little technical issues there on the front end of the call. We want to make sure that we have a great and smooth experience for everyone as we go through today's presentation and some respondent comments, and we hope your questions as well. My name is Anna Hoover. I am an assistant professor at the University of Kentucky College of Public Health, and I am the co-director of the RWJF Systems for Action National Program Office. It is my pleasure to be your moderator today for some exciting research that we have funded coming out of Colorado. I want to just quickly give you a thumbnail of what we're going to be hearing about and who we're going to be hearing from today. Today we're going to be hearing about strengthening the carrying capacity of local health and social services agencies to absorb increased hospital clinical referrals from a team in Colorado that is led by Dr. Danielle Varda. Dr. Varda is the CEO of Visible Network Labs. She's also the co-director of the Center on Network Science and an associate professor in the School of Public Affairs at the University of Colorado, Denver. She was previously at the RAND Corporation, where she worked as an associate policy scientist. Dr. Varda specializes in collaborative governance and network leadership, focusing specifically on the impact of social connectedness on health and well-being outcomes. Her research focuses on evaluating the network structure of interorganizational collaborations between the public, private, and nonprofit sectors and the subsequent network effects of these recorded interactions. After Dr. Varda shares some of the emerging findings from this ongoing work, we'll be hearing from a community partner, Dr. Cameron Hodgins. Dr. Hodgins is Executive Director and CEO of the Glasser-Schonbaum Human Services Center. Dr. Hodgins has a PhD in lifespan developmental psychology from the University of Alabama at Birmingham. In 2007, she became the Vice President of Programs and Services at Easter Seals, Southwest Florida. And in October of 2014, she joined the Glasser-Schonbaum Human Services Center as the Executive Director and CEO. Dr. Hodgins is local lead for the case study in the Sarasota, Florida site. As we go through the presentation and hear from Dr. Varda and Dr. Hodgins, we ask that you please use the chat box in the bottom left-hand corner of your screen to tee up some questions, because after we hear from our two speakers, we'll definitely be getting to participant questions, and we want to elucidate the issues that concern you most as attendees. So with that, I'm going to hand things over to Dr. Varda.
Well, good morning, everyone, and thank you, Anna and Lizeth and the team over at UK who help us so much in supporting our projects. It's been such a pleasure, again, to get to work on this one with you. And I am pleased to represent our team here. I am on the phone representing kind of a large team of people, here we are, who are from a few different areas of the country and also different sectors. So we're truly a cross-sector community research collaborative team. I'll give a little bit of background on that. Anna just introduced myself and Cameron, but we also have members of our team from the University of Colorado, Denver, Dr. Todd Ely and Melinda Mochizuki. Dr. Rachel Graham from the University of Kentucky is one of our research partners. And also, and I know most of these people are on the phone, so I know I'm representing them as well. Katie Edwards is the Executive Director of the Nonprofit Centers Network and works out of Denver. And Carly and Kinsey from Serve Denton are another one of our community partners. And you'll be meeting Cameron today, and her partner is Charlene from the Glasser-Schonbaum Human Services Center in Sarasota. And Sarah Lampe is part of our fiscal sponsor partnership from the Trailhead Institute. So a quick little background on how we all came together. When we wrote the proposal for this grant, we really tried to figure out what kind of problem we might be able to address that communities were facing. And because we had all been working in some area of building capacity in the nonprofit public sector for some time, we took that knowledge and background that we had together as different team members and tried to really think about how that relates to some of the biggest issues in healthcare and health change today. And we put together some of our thinking around how a lot of health systems, clinics, other kinds of social and human service organizations are beginning to screen people more commonly around their social determinants of health, their social and economic needs, and how by doing that kind of screening, it's leading to more referrals into the public and nonprofit sector. So while that is monumental, and we are absolutely thrilled to see that kind of work happening in the healthcare sector, as people who represent the nonprofit and public sector, we knew that that had implications for those people and resources that work in that sector. So we began to ask the question, how is that going to impact the folks who provide those resources once people are referred out into the community? We noticed that people would refer to, referring people out to community resources, and if I was in person, you would see me putting that in quotes because it kind of stopped there. In a lot of our early conversations, there was a very little understanding of what that sector looked like, how it was resourced, and what kind of capacity it would have if those referrals became increased. So for that reason, we set up a project that had a few aims, and one is community resources there, actually in quotes, was something that we set out to define. What do people mean when they actually talk about referring out to community resources? What are we talking about? And how do we address some of the misconceptions that people may have about what those resources are and how they're funded? And then really try to determine what factors would make up that system that both, provides the inputs and outputs and how it all interacts together. And then identify existing and potential financing mechanisms. So how do we align the financing and policy mechanisms across those efforts so that not only can we see successful increased screening of social determinants of health in health systems, that's amazing, but how do we make sure that there's receiving capacity on the receiving end of that so that we can strategically think about where can we invest in those sectors when those patients and clients are coming out of those screenings and being referred out into the sector. And then we really we're seeking to determine some strategies and even tools about that kind of work. So you're going to see me talk a lot about our team. I came out the gate that way. What we're going to focus on today is the relationship that we have with our community partners. So I am going to go through some findings of one of the phases of our project, but what's really remarkable about this project is this community partnership that we have, and we want to really demonstrate how this work is translating into communities. And so Cameron, who's on the phone with me today to present, is one of our community partners. So I'll present some of the early findings around our network analysis work, and then Cameron is going to really talk about what that's meant inside their community and how they're translating that into practice. And this really shows how we've mixed our community partners, mix those roles. Our community partners come on to a call with us. Our research team has our own monthly call or biweekly call, and then the community partners also join calls, and they're a part of each part of our study. So they're a part of design, they're a part of administration, they're a part of interpretation, and now dissemination. And so it's a real authentic partnership, and so we really want to highlight it on this webinar. So just a little bit about the problem and some early results on one part of it. We drew this picture for our grant, and we've been using it ever since, but we kind of know what the current system looks like. We know that there are health systems and community organizations that treat patients and clients, referring people into what we call the nonprofit public sector for these kinds of social and economic service resources. So in the nonprofit sector, there's a ton of work that's been going on for years around what the carrying capacity of the nonprofit sector is. I wrote a paper with some colleagues years ago around how we can ask questions about how we can increase the capacity of the sector if we take collaborative approaches to thinking about how to resource things. But what we do know is that the sector varies a lot, but a lot of it is tapped out. And what that means is that there's a lot of organizations that already provide all the resources that they possibly can to as many people as possible. So the idea that more people, which is kind of our next slide here, are going to be resourced. So those green arrows are new referrals that are coming from these different organizations out into those different, and by these resources, what I mean is, not only food transportation help, childcare, domestic violence resources, all the different kinds of ways that we know people need help that address those factors that address their health and wellness. Those are the things that these folks typically provide. It's the social service sector. So being already at varying capacities, if we start to increase that referral out into those communities, we hypothesize that we will quickly see increases in capacity unless we begin to align the financing and policy mechanisms to build the capacity in the sector. And we also are very familiar with how these kinds of organizations are financed, and given that most of them are not fee-for-service, which is a misconception of how most of them are funded, but rather funded by philanthropy, grant dollars, and donations, we know that they're very fragile in the ways in which they are able to build their capacity and respond quickly. So it's not really a good system that's in place right now. There is quite a bit of potential for it to overwhelm the nonprofit and public sector very quickly. And what's great is some of our colleagues who are also part of the Systems for Action grants are addressing many of these issues in innovative funding mechanisms, especially through things like Medicaid coding and things like this. And we are so pleased to see that happening. So it fits really well with what we're doing. So to address that issue and to do this project, we did have a partnership established with these two community partners, Serve Denton, which our Serve Denton partners are on the phone but not presenting today, and you'll see a little bit more from Cameron about their organization in a bit. The methods that we are using to do this include we started with secondary data analysis. We have a lot of data from what we use the partner tool. I'll talk about that in a second. And we have a lot of secondary data that's come out of that, about 4,000 networks all over the country, and really nuanced and detailed information about all of the interactions in those networks that are cross-sector, community-based networks of very different kinds of organizations. We, and Rachel Graham and I did a paper that we published in Health Affairs that really just described what the nonprofit sector looks like in these community health kinds of networks. So we did a lot of work on that just to do some exploratory stuff. We developed a conceptual model to guide our future phases of the project. We visited Denton and Sarasota and did key informant interviews to really understand what kinds of ways and processes and policies are already in place when communities are actively referring from their health systems into the social service sector. And these two communities, luckily Katie Edwards from the Nonprofit Centers Network helped us to identify these two communities that kind of raised their hand and said, we're thinking a lot about this and we think we're doing it well, but we also aren't sure. So it was a really great partnership to know that there's this very kind of active stuff happening in the community and a lot of interest in investigating what that looks like. So we did those interviews, and we've actually just submitted our first paper for review from the findings of them. And those are fascinating, and we've presented that several times, and I'm not going to present that today. And then in last fall, we went ahead and we said, okay, now let's do a network survey. And we'll use that network survey and we'll start investigating some financing data to try to understand, can we build some kind of tool or metric to help folks understand what carrying capacity looks like in the social services sector? How do we actually create something that people can put information in and then use either when they're applying for grants or communicating back where they have capacity or not? And we used a network study to do that. We are right on track. We've done our network analysis, and our team is in the middle of building a capacity model. So Todd Ely on the team is our health economist, or our economist, and he is working on developing the first part of the model, which basically looks at financial indicators, for example, from, let's say, a 990 or an annual report, that we can start to develop into a set of measures, very simple and easy to understand measures that we can use to understand the capacity of these organizations. So, and then we have a little bit left here to do, and it's not often I say we're right on track, but we are right on track with this project. And And I said I was going to do the network analysis review today. You can imagine it's just one part of a very, very rich study that has a lot of interaction with community. So we're narrowing right now in what we're showing you all today. So I'm going to go through a little bit of our results from our network analysis, and then I'll turn it over to Cameron. We've had such a learning experience together figuring out how to use every stage of the data to figure out how it's going to build the capacity of the community to both communicate to others and make strategies and think about their next action steps. So as much as we're doing research, we're also really actively trying to implement a community engagement strategy here where these community partners are really getting some value out of the work as well. Okay, so I'll go through a little bit of our social network analysis. I'll do this for anyone on the call, but it's like the quickest way you could possibly talk about what a network analysis is. Network analysis is a methodology that collects data on who's connected to whom, how those connections vary and change, and we focus on patterns of relations, and that's how we make sense of our network map. What we do is we try to understand better the quality of connections and maybe the frequency of connections, where there might be gaps and where there might be strengths. We talk about nodes and lines, and the nodes can represent people, organizations, things. As we study systems more than maybe bounded networks, those systems involve all of the kinds of things that we're putting into this. So maybe like the finances of an organization, as well as thoughts and ideas and things that we share. So those nodes can represent other things. The lines would represent a relationship in whichever way you defined them. So for example, this little picture on the right, if this was a survey where we asked the folks who are listed here to say who is a friend of whom, we would see that Garth said he was a friend of Bill because the arrow is pointing that way in the survey, and maybe he rated it on a 2 on a scale of 1 to 3. We see that Bill didn't say the same of Garth, which means he might not think of Garth as a friend. He may define friendship differently, or maybe he didn't answer the survey. But that's how a set of network questions, we call them relational questions, get asked in a survey, and they turn into maps like this. Network data produce enormous amounts of data, far more than a typical survey. So it's important to think about how you construct them. Lastly here, before I two things before I get into this. What are we actually measuring? So this is a question that comes up. We do a ton of network studies at Visible Network Labs and Center on Network Science. This is our forte. We do network systems evaluation and build tools for that. But really what's happening here is on the left side of that picture, sometimes I do this as a build and I can automate these out. So I kind of gave away the answer here by not. But on the left side is partnerships. What we're doing, we're trying to build collaborative connections, relationships that are going to be advantageous for our outcomes. So we do that by maybe convening stakeholders, doing needs assessment, talking about leveraging resources. I'm sure everyone on the phone is well engaged in the network way of working because it's just the norm today for how we do things, especially in public health and healthcare. It's remarkable I just said in healthcare. That's actually newer than it has been in public health, where we've been doing that for so much longer. And then those partnerships, usually what we're worried about, right, is how is that affecting our outcome, for example, child and family outcomes. So we want to know how our collaborative work is affecting our outcomes, but the truth is what's really happening is that middle box, which is all of the systems or network outcomes. That work right there is process. It's the thing that we are all struggling to figure out how to do really, really well so that we can get to that outcome. So in a network analysis, we're really measuring that middle box. You know, what are perceptions of things like value and trust and authentic relationships, goals, outcomes, and processes, and including measures of things like coordination, efficiency, and redundancy. I have down there the way in which we're couching this, especially today, is among organizations and set in a community context. That little box at the bottom can change very much. It could say among families set in a healthcare setting. You know, so the context in which the measures are interpreted matter so much. And so that's really what we're presenting here. And then what we are really super committed to, my team and I, is figuring out how do we use that information then to translate to practice, to manage it. And that's why this partnership with our community partners is so important to us, because we love doing research, we love publishing, but what really gets us up in the morning is figuring out how to use this kind of data for community improvement and strengthening partnerships. We use a program called Partner. It stands for Program to Analyze, Record, and Track Networks to Enhance Relationships. You can find it at partnertool.net, and it's basically a survey. It's a data collection platform for network data. You can collect data using a survey builder where you can ask network questions. You can use an app to collect data from personal networks. That's a whole other talk. And then it has a back-end whole data dashboard system where you can do all your analysis, look at the insights library, and build reports. So we use that tool in this project, and what Partner does is we can map, we can do visuals of network connections, we can add attribute information to see that. You can see the little picture on the right is just a very simplistic way to describe some ways you can think about things like seeing which organizations are connected to each other, how they're maybe embedded in a larger system or community. You can measure quality of connections and then use that information for strategies. Okay, so let's get into a few results here. So when what we did is we worked in partnerships with our community partners to identify who would be a member of this network. We did bound the network around the area of housing because we had to pick something, right? We couldn't just go out and say, like, who's working on social economic, resources for people in the community. So we did it around housing, and we developed 2 sets of network lists of partners, one in each community. And we administered the survey. Many of them had also been interviewees in the earlier part of our project. But we did send those out, and it was a cross-sector list of health systems, law enforcement, public health, all the folks you can imagine. And we asked them to answer these surveys. Our response rates were very high, actually in the 70s. I didn't put the response rates up here. So we got a lot of buy-in, and the community partners were amazing at that. And we were able to do a lot of network mapping. These are the only maps you're going to see, because if you know me at all, you'll know that I think the network map is really like the front cover of your network story, and it's all that data, rich data behind it that you can collect using relational questions that make it really interesting. But for example, here's a map. You can see the type of sectors that were included in the group key down there on the right. You can see here, I just pulled out one set of maps and one nuanced difference. So when we ask these partners to indicate who they connect to around client referrals, you see a gray line when they said they do that. When we ask people who they connect to around client assessments, then that's the map on the left. What was interesting about this particular one data point out of hundreds at this point was that we noticed that there's a lot of referrals happening in places where they're not also doing assessments. So in this world, it's just a very nuanced point that I found really interesting, that in the world of, how are we screening people to get them to the right resource out into the community, we may be lacking in some resources and science probably around doing that really well, which I know a lot of folks are working on, although we are just referring. So I just found that to be one interesting data point. I'm really trying to be kind of narrow and quick here, so I won't go into too much more. And what you're seeing here are a set of scores, and I have the green box on the left is me blocking out any organizational ID. So you won't see who's who here, but we thought it would be interesting. Some of the interesting data we got are things like density, some traditional network scores, centralization. This is Sarasota's data, and it's particularly rich network of relationships. It doesn't surprise us at all that communities have a ton of relationships. So our job in a network study is to kind of go through that and figure out where the nuances are and the interesting points of information are. The trust score is really high. What you're seeing there, kind of small text here, but what's circled is it's a special way of asking questions from the partner tool. When partners answer questions about each other, there's a scale of value and a scale of trust. Value is made up of 3 measures. One is power and influence, level of involvement, and resource contribution. So respondents rate their partners on those dimensions. So these are measures of perception. Trust is measured in 3 as well: reliability, mission congruence, and openness to discussion. And so the words value and trust are not used. These are really interesting data points that we get. So what you're seeing, the circle at the top, is basically people who have high scores. The scale is a 1 to 4. And what you see there are some each row is an organization, a partner in the network. What you're seeing there is, not surprisingly, people who are high value and high trust. So that happens in every community. What you'll see in the next, what I circled down low, is an example of where the trust score is quite high, but the value scores start to drop below 3, and 3 is our benchmark for good. So what you'll see here is you begin to see variance where maybe people are trusted, but their perceptions of their value to the work lowers, or vice versa. Perceptions of value is very high, trust becomes low. So there's a lot of work you can do here with these scores in really trying to understand. I always say to everyone, there is really no real measure of a partnership or a relationship rather than the perceptions we have of each other. I mean, all of us are on this webinar together, so we could note that, but a real relationship is the perceptions that you have of me and that I would have of you. And if you can capture those perceptions, the power of understanding and being able to work with that is so heightened. It's so great. So that's one way that this is used. So just to finish, I'll run through a couple of our less relational but interesting findings. And this is starting to compare Sarasota and Denton together. We asked people in the survey, how successful do you think efforts to address unmet social needs through referrals from hospital and health systems to community organizations have been in this community? And what's interesting here is the variance you'll see. So in Sarasota, you see this almost split of people agreeing that it's somewhat successful and then somewhat unsuccessful. This is such an important point in a network study that as interesting as that finding is, what's more interesting is that we call it dispersion of the agreement on answers gives you some sense that there's something happening in the community where everyone's not quite on the same page of how well things are going. So really interesting data point. On this one, it's so hard to see, but it says, what aspects of the referral process are working well in your community? So actually, I think that, so I know that, Lizette, you said you edited these a little. So the circles are on the wrong spot here, and I don't know if you can see it. But basically, what was interesting is that in Sarasota, number 1 on both lists is partnerships with community-based organizations. Number 2 on Sarasota is partnerships with law enforcement. We all found that really interesting. 19 respondents picked that as working really well in the community. So that's pretty unique to Sarasota. You'll see it falls down the list on in Denton. It's not something as prevalent. So ignore those circles. They're in the wrong spot there. This says, to what degree is your organization able to quickly expand services? So this is the carrying capacity question. And what was so interesting to us is that most people thought by a fair amount they were able to quickly expand services, and some even said a great deal. What factors have the greatest impact on your ability to continue to provide and sustain services for your clients? So funding was number 1, which we're not as surprised about. And you can see that the top 5 categories or so on each one didn't vary too much on what they said. So it was things like collaborative opportunities, strong relationships, staff capacity, cost saving, and financial efficiency. So not as surprising there. But we asked, what kinds of funding model sources do you use to sustain your organization? And you'll see that most people said grants, donations, events, fundraisers, or contracts. You'll see that fee-for-service falls down the list there. In Sarasota, there's a little bit more of that. But what we've noticed is that there is some kind of perception that some of these organizations have fee-for-service, meaning that they can be reimbursed when they are serving their clients. And that's actually not very true in the nonprofit sector. Some of our larger organizations do behave that way or run that way. But most of the nonprofit sector, which I think over 90% of them are very, very, very small, think like a food bank or a domestic violence shelter and things like this. Most of them do not function that way, so they have very limited bed space, very limited capacity, and sending new referrals out to the community does not necessarily translate at all to greater revenue for those organizations. So it's a real kind of kink in the system that we're trying to address here. This was almost one of the most interesting, though. When we asked everyone, how financially stable do you think your organization has been? Hands down, people said very stable. This has been really interesting as we've been comparing their actual financials to their perceptions of, or reported perception of stability. It's interesting because what you almost see is people who are very stable will report that they feel unstable. And then alternatively, you'll see some that are not very stable, if you look at their financials, who report feeling very stable. So this is probably a whole area of study for the nonprofit sector, like how do we address this issue of stability, but it's been leading into what we've been working on. So that's all I'm going to present today. What we are really doing very nuanced right now, Katie and Todd on our team are working really well on creating a financial model that we can create that has just a couple of data points that can help us talk about carrying capacity. What our ultimate goal is to publish, work with community partners, and the third thing is to build a tool. One is a very simple tool that might have like 3 to 5, maybe up to 10 data points that will be secondary, so you can go and grab those data from somewhere in the community, information or data that organizations typically have, put it into our spreadsheet and be able to really not predict but understand some of the capacity nuances inside these communities. And we're doing this at the community level, not the organizational level, so that's been a challenge for us. And then we'll also create a version of that tool that can incorporate, if that community wants to collect data, like run a survey, you can get these other data points and we'll put those into the model. So our goal by the end of this project is to have 2 versions of that tool, one that's very easy to use, one that's a little bit harder to use, and we'll be pilot testing those inside these 2 communities. So I went on a lot longer probably than I was supposed to there, so I'm going to turn it over to Cameron now to talk about the community's perspective on all of this work. So Cameron, go ahead and take it away.
Thank you, Danielle. Thanks a lot. It's a pleasure to be here. So I'm Cameron Hodgins, the CEO of the Glasser Schoenbaum Human Services Center here in Sarasota, Florida. And let's see if there we go. Just to give you a little background on my center, we're 30 years old, and we've got 20 nonprofit organizations that are in a shared space center here. That's the list of them, and you can see more on our website if you're interested. We're on 14 buildings. We have 5 acres, obviously the one campus. We have sort of a tri-county reach. We are about 60 miles south of Tampa on the west coast of Florida. This tri-county reach maps directly on top of our circuit system for our court system. So a lot of the court-appointed programs for social services are referred in this tri-county region, which is sort of why we operate in that fashion. We've had 58 agencies here over the 30 years come on and off the campus, and there's some more stats there, about 48,000 square feet of office space. This is why they all want to be here. This next line, $8.50 a square foot a year is what we charge them in rent. And so for that cost, they get all their overhead and maintenance expenses paid for by us, except for their phone and internet. And so it's a really, really great deal. Just to give you a little bit of perspective, about average cost of rent, office space rent where we are is about $16 to $18 a square foot, and that does not cover CAM or triple net fees. So it's a really great deal for them. So in the time that we've been here, we've saved about $16 million in their overhead expenses. And to present day, there's 118 programs being delivered to the county, to those tri-county region, with about a $17.4 million collective budget here, serving 26,000 individuals, and then you can see the staff breakdown there, and of course mobilizing a lot of volunteers. So I always, it's hard to talk about a community if you don't have any context, and the more I do this work, and I'm a native Sarasotan, which is really rare, but the more you do this work, the more I realize it's sort of a tale of 2 cities. if you're somebody on this call who's been here for a vacation, which many people have, it is really a beautiful city. We have so much to be grateful for. The Ringlings of the circus kind of founded this place in the 20s, and so I always say it was settled by aristocrats and carnival people, which is pretty interesting, and we sort of still seem to be that way. We haven't really evolved much from there, and I'm so proud of my city, but we do have a lot of poverty and something that the United Way calls Alice families. And 51.2-ish% of our children in Sarasota County are on free and reduced lunch. And there is a ton of wealth here. I just looking at some research this morning, we were 4th in capital gains last year, above New York City. And so a lot of people retire here. There is a ton of wealth here. What's particularly interesting about our community in the context of this study is we've got 3 foundations, two public, 2 community foundations, and 1 private. And if you count in 2 other private foundations, family foundations, there's about $1 billion just in those 5 entities right there. And so they have a lot of power in the community, and they have a lot of leverage with pulling organizations together to move the needle on some social change. And we all listen when they speak and respond to the best that we can. 3 of them were a part of this research, so which was really, really awesome, and I'll get more into that and how that works. But more about Sarasota, the interesting thing with the police that Danielle mentioned in our relationship with law enforcement. I will say that our police, both city and county, have really stepped up to help in the space of homelessness. And Danielle mentioned that this study was kind of framed in housing and homelessness, and I think that's why the police variable is showing up so strongly there. We stopped criminalizing homelessness and started to have better partnerships with large providers of homeless services. Salvation Army comes to mind. And the police force was really active in educating themselves on why that was important. The other demographic that we sort of really seemed to shift the police on was human trafficking and how to treat women and actually the men involved in that differently in our community. And that has driven more people into social services and away from criminal justice. And so it's been a tremendous shift that I've seen in just the 10 years that I've been here doing this work. So where this has been interesting, especially for the funders, the strength and the relationship of the nonprofit community. So for these foundations, they're very interested in A, do we all know each other? B, how well are we working together? And C, where can they increase capacity and where to be strategic about it? So I'm going to give you an example there in that underneath that second bullet point. There's a current project going on called First 1,000 Days, and it is across the country in different cities, but it's focusing on pregnant moms who may not have access to health care or who are showing up to deliver their children and indicating maybe 1 or 2 prenatal visits or 0. And so the commitment of this foundation, the Charles and Marjorie Barancik Foundation, is to make sure that these moms, once they're in the system in any capacity, are followed for the first 1,000 days of that child's life, which is birth to 5. So what does that mean for our community? Well, we're about 18 months in now. They've pulled together many, many providers who are in that space, including the hospital. And when our primary hospital here is called Sarasota Memorial, very well known, very well respected. But what was interesting in our data set was we were, and Danielle showed this, referrals from the hospital weren't happening from the hospital out towards us. We may have been, as providers, referring people to the hospital, but we felt like they didn't quite know where we were. And the Barancik Foundation got wind of that, and so what have they done? They've now, as of last week, finally have 2 full-time staff members at the hospital just working on this project, a coordinator and then a case manager. And I think it's going to have to ramp up quite quickly after that. But the coordinator has spent a lot of time getting to know the nonprofits in town, and the case manager will then be working with these families, and especially these moms, making sure these families don't fall through the crack. When the CEO of the Barancik Foundation, her name is Terry Hansen, found out about this data, she said, I just want to see the subset of the people who are in this first 1,000 days. So I have our big data set's 40-plus partners, but the Barancik subset, the first 1,000 days subset, is about 17. And Danielle showed you kind of, I call it the spider web, but the picture with the nodes. It's very interesting with the 17 partners. You can see the intentionality of the partnership. You can see more of a balance. The dots aren't as far apart. They're more of the same size. The centralization is less, which is a good thing because that means if one of the partners fell out, the rest of them could share that responsibility sort of equally. And so they were very fascinated by, I mean, their efforts were intentional, but to actually see it measured and graphed out, it was reaffirming to them that they were on the right path. And so that CEO now has taken that data to her board of directors to say, look, we're doing the right thing. And so and Danielle doesn't even know this, but I met with the project manager for Brandsick on Monday and the project manager for First 1,000 Days from the Hospital on Monday, and they're so excited they want to do this in another 6 or 8 months, maybe 12 months when they have more data to see if the relationships between the nonprofits has shifted at all or has improved. So those are very intentional. The other question that they had actually on Monday was our community's continuum of care. That's our homeless management system and all the communities, all the nonprofits represented within that space. Have we looked at their network? The answer is no, because not all of them have taken this, and every person in it has to answer questions based on everybody else in it. So that would almost be a whole nother sending that out to this continuum of care community. But that would really be fascinating to look at that particular subset of partners there. So I really would like to do that. Homelessness is a big problem here, as you can imagine. If I was homeless, this wouldn't be a bad place to be. It's pretty most of the time, and the weather is good, and people are generous. But as you can imagine, it does hurt our business community and investors and those things too. So there's a lot of effort going into the prevention of homeless, rapid rehousing, all of that good stuff. But there's still a lot of sort of community chatter about, is it effective? Are we working together well enough? That kind of thing. So our COC would probably benefit from looking at this. Where it has been interesting, and I say interesting almost, and I have it here in that third bullet point, opportunity, is some of the data could be sensitive to certain partners who may perceive themselves as more connected with other people as other folks did with them. That's kind of where I'm struggling right now, to be quite honest, is what to do with that data. Should I show them? And a really good example of that is one of the foundations who, this was sort of surprising to me, one of our local foundations, community foundation, that didn't rank so well perceived by the other nonprofits. And I have not told that CEO yet, and I need to, and actually my board chair is her board chair too, so we share a board chair. But I would, and I am going to do it, and I think I'm going to use it as an opportunity of their marketing and their messaging. Like, look, here's what you say you exist for. Here's how the nonprofit community sees you. What can we do to sort of bridge that gap there? And maybe or maybe that's what you want it to be, But I think there's opportunity there. So there is some sensitive data in it too. And I think a responsibility of myself and my team, and even Danielle's team, is, what does this mean, and where can that be used to enhance relationships? And then about relationships, I love Danielle's point that more isn't always better, and the intentionality is really important. And we all know, we all feel this in our personal lives, that we only have so much bandwidth to give, right? And Sarasota and the funders here sort of push, everybody should work together all the time, constantly, yay. And at the same time, that can be overtaxing and overly burdensome. And so I think I love this data because it's really showing that intentionality is better and purposeful relationships, rather than everybody just saying, yes, we're all in this together, let's do it. It's really not as effective that way. And I think you're seeing that a little bit in the side-by-side that Danielle showed of the referrals versus what was it, Danielle? Referrals versus
assessments.
The other one. The assessments, there we go. Thank you.
Assessments, yeah.
Yes. So I think you're seeing some of that there. And the other, going back to my slide, my final piece, come on, oops. Yes, and then the longitudinal opportunity is there. And like I said, I already have the First 1,000 Days group talking about it. I would love to have, like I said, the COC and I think other subgroups that work together a lot would like to see this. The healthcare system, I didn't mean to skip over that one. So I know this sort of anecdotally, and I had told Danielle and the team that Sarasota Memorial has built some little sort of outpatient sites across the community. One is in a neighborhood just a few blocks north of me called Newtown, which is our historically African-American neighborhood and underserved with a high level of need. And when they first opened their doors there, and this was like 2 years ago, they were flooding our campus here with phone calls and visits because they had so many people walking in who acknowledged having other issues in their household besides high blood pressure and and diabetes, and needed other things for domestic violence issues and food in their house. And the hospital staff that had been placed at this off-site clinic were woefully underprepared to answer those questions or even know where to refer these folks to. And so that was really eye-opening to me. They didn't have room for a case manager in that building, and they were sort of coming to us. Now, we were pointing them back to 211 and other resources like that, but also, taking those calls as they needed. Now, that has kind of died down, and I think they do have case management over there. But I was surprised personally how that system didn't really understand what resources were out here in the community, and it showed up in our data set just like as I thought. So they recognize they have a lot of work to do. I think Barancic bringing that first 1,000 days into the hospital is a really awesome start in educating the hospital on what's available. And, I don't know that they've seen themselves that way. I mean, their primary care, their emergency care, their treatment care, but then what happens after and coming into that next step. And one thing I wanted to tag on about Danielle's mention of the financial stability of the organizations, I know Todd Eli's working on that with some 990s. The 990s are a smidge tricky because, I have a Salvation Army on my campus, but that's not their main location here. So what their 990 shows on their budget is really large, and it probably includes what's here on my campus, but also their big shelter a few blocks away. And so teasing apart what is where and what's actually happening is tricky, and I really respect this team for trying to dive in there. But that's interesting that the more resources they have, the less they think they're able to respond, and the less they have, the more they think they are. We're not quite sure what that's all about yet, but I'm looking forward to knowing more. So I think that is all that I have, and I'm going to run through these questions. Let's see. Go ahead.
Thanks, Dr. Hodgins.
Yeah.
This is Anna Hoover back, and I'm going to tee up some questions that folks have been asking over the course of the webinar. If you have additional questions, please be sure to use the chat box in the bottom corner. The first question I'm going to toss out here is actually a question for clarification, so these are going to come a little out of order if the speakers are looking in their chat box. But this first question is a question of clarification, which is, how is the fee-for-service different than reimbursement and or contract? They seem to be overlapping.
Yeah, and I agree they are overlapping in many ways, but the reason we did that was to tease out what is fee-for-service and is not contracts or reimbursement. So people can pick more than one, so we would guess there is overlap in the answers. But fee-for-service is pretty specific. It's usually at the individual level. You serve one and you can be reimbursed for that service, versus a contract that could be, a contract either for services provided to individuals or contracts for other kinds of things that those nonprofits or agencies might provide. And reimbursements are a little bit similar. They can be aggregated. So what we were trying to tease out there is what is specifically fee-for-service. So totally agree there's overlap. It's one of those survey questions that we toyed with a little bit, but that's the reason that we called it out that way. So yeah, we'd have to acknowledge that there is overlap, but they could be included inside each other as well. So really good question.
Thank you. As you noted in your presentation earlier, Dr. Varda, partner tool and social network analysis have been used in the public health community for some time. So I think we have a group of people on the line who probably have used partner tool for their local public health departments or state public health departments. And so we have a subset of questions that tie this work into that public health realm. As you know, Systems for Action does work toward aligning all three, the medical, public health, and social services and support systems. So we have a subset of questions about linkages to public health. So the first one is really a two-part question. Does the network analysis in this project extend to all partnerships with health departments? Do you feel that the networks defined in the project contribute to strong examples of collaborations involving public health, healthcare, and social services?
Well, those are great questions, Cameron. You might even have some to say on this as well in representing. I love the idea that people on the call might be part of our partner tool community. So thanks for saying that. It warms our heart, actually, to think of that. So thanks. And the two questions are really good. Does the network analysis in the project extend to all partnerships with health departments? I mean, the answer is a definitive no, right? Because this project, the reason I say that is this project wasn't meant to represent all networks at all or all public health departments and their partnerships. It's the nature of a network study, the context in which that network is being studied, meaning the historical nature of that community, the funding that has gone into that work, the culture of collaboration varies so much. So what we had to do, so in this case I would say no, each network study is pretty biased, I think, to the community in which it's been collected. That said, you know, like when I said that we have a huge data set that Rachel Hogg and I have worked on, we have 4,000 networks with 60,000 organizations in it. So it's, in that way, we try to do more generalization and understanding across larger, data sets of networks. But so that's my quick reaction to that one. And then the second part, and then I'll let Cameron answer. Do you feel that the networks defined in the project contribute, I think, to strong examples of collaboration involving public health, healthcare, and social services? I would say without a doubt, yes. In this case, the hardest part of a network study always, and I say this over and over again, I've done hundreds of these, is bounding the network, is trying to understand who to include in the network study if you're going to do a bounded network study. So the thoughtfulness with which this team put together that list was to intentionally be representative of that. So we picked the folks that would be included in it, but it was informed by the community experiences and knowledge of who is involved in that work. In Sarasota, I can speak to them, and similarly in Denton, it is a rich network of connections, and we had to bound it to housing so that we could get our hands around it, because you can imagine all the other types of ways in which they work together around different issue areas is pretty rich. But what do you think, Cameron, about that?
Yes, about the public health. I mean, I just happen here at my center, we've housed the pediatric public health clinic location since day one of our public health services here, and actually we're able to build them a new building to expand their capacity. They've recently moved OB services into that clinic, and we've added pediatric dentistry there. So we've had a long history of the partnership between this nonprofit and the public health services, and our county seems to play well in those buckets, and then of course private donors helping all of that come together. I think my community really recognizes that nobody can do everything alone, so the working together piece is really important, and long history of just picking up the phone and calling somebody and knowing who to call to get something done, and so that really helps. I can't say that it's the be-all, end-all. I will say, though, that I think we have a public health department in the very southern part of our county that is run by, it's sort of like a multi-service center, but it's run by the city government, which seems to be kind of a different entity than if it's run by a private nonprofit. I mean, we're not private, right, but a nonprofit like we are. We have a little more flexibility in our design and our intentionality and our partnerships than the city government would, so that's a little bit of a difference there.
Thank you both. We have one more sort of public health adjacent question, and considering the boundary pieces that Dr. Varda just outlined, these might be a little afield from this study, but given the many thousands of data points that you have and have worked with over the years, you might have a perspective to share on this. Someone who is interested in learning more about the partnerships with local public health departments that also get referrals from hospitals and nonprofits. As more health plans are looking at social determinants of health, how can health agencies partner with health plans to get reimbursement or some revenue to help braid different funding streams? And again, I recognize it's a little removed from the specifics of this study, perhaps, but if you have anything you'd like to share on that.
Well, I mean, what I'm struggling with is like the Systems for Action grantees in our cohort. When we get together as a group and annually we have the opportunity to do that, I would say there is the answer in examples. Because what we're trying to do is figure out how can someone raise a flag, right, to say like we need capacity in this area if you're going to continue to refer us out. And there's a whole system of factors that have to go into making that kind of statement, right? But the innovative financing mechanisms around how these kinds of relationships can happen is happening all over, and it's so motivating to see it. It's not easy work. And something I often say, so I would refer that question, actually go back and look at the website that the UK team here has, the center has put up about all the projects, and you will see example after example of that. And this is kind of one of my favorite things to think about. And I know there's new cohorts of grantees and Systems for Action that I'm not as familiar with. Our cohort, I have always felt if you put all of us grantees together as one project, boy, you would have an awesome research systems project happening, because that we're doing it, one off from each other is amazing, but we're really answering a bunch of systems questions together. So, there's so much in there that's even beyond what I think we know. And so I think all the parts of these questions together, it's a really awesome kind of thing that's happening around study of this work. So.
Thank you so much. And you're exactly right. It's that old saying about how do you eat the elephant one bite at a time. And these studies are all looking at different bites, right? They're all tackling different bites. And there are studies looking at things like new terminology systems for aligning health and social services integration, financing integrated health and social services for populations with mental illness, optimizing governmental health and social spending. So there really are projects who are looking at these different facets. And I welcome you to visit the website, check out the other archived research in progress webinars. Now, I know we're almost at time, but since we did start 2 minutes late, I've got time to get in one last question. One thing that this presentation has really highlighted, both Dr. Varda and Dr. Hodgins, is how important context is for thinking about how these systems work together, for thinking about what that carrying capacity looks like in these different contexts. So we have a participant who would like to know more about information or data regarding impoverished areas. It was mentioned several times, I think by Dr. Hodgins, how financially stable the Sarasota area is. However, how would this model work in less stable communities?
I actually think it would be more informative in less stable communities. And the point of me talking about Sarasota that way is like it's truly just like a huge divide between what the communities in need actually need and what the people who have capacity to help with know. And so a study like this is so needed in my community to bridge those two, to bridge that gap. It's one reason I'm so excited about it. I think, though, and I'm a little bit speaking for Dr. Varda, but this study could be anywhere for any population at any time, hugely informative across any community.
Yeah, well, I would just add one thing really quick. We acknowledged that when we got to Sarasota, we were like, wow, the foundation role in this work is so unique and different. And so that's been something that we learned a ton from. So I would just encourage, I know we need to think about it in all these areas too, but you can learn from these different factors that show even, different ways that these systems interact. So, yeah.
Well, thank you again, Dr. Hodgins and Dr. Varda, for a really interesting discussion of this exciting research, and we're eager to keep following it as you continue advancing and learn more about the tool that is being developed and will be transferable across a number of different settings. Thank you all for joining us. If you'll have a look on your screen, you will see our upcoming webinars looking at other facets of the Systems for Action research portfolio that are examining different kinds of alignment mechanisms, some of them finance related, some of them carrying capacity related, looking across a number of different sectors. So we do hope you'll join us for those. We also have, as I mentioned earlier, a number of webinars archived, I believe about 60 Research in Progress webinars archived over the last 3 years. So if you're interested in exploring some of these other issues that have arisen, please do visit us. We hope you'll join us again soon. Thank you so much and have a terrific day.